Mr. Chairman, ladies and gentlemen, first I want to thank the organizers for inviting me. I am very happy to be with you today, again in Lebanon. So I was asked to talk to you about aspirin and prevention of venous thromboembolism. So you use this, okay. Okay. So there are many indications for prevention of thromboembolism, especially in medicine or in surgery. So what are the anticoagulants used for prevention of venous thromboembolism? And we can see none of them is ideal. If we look first at unfractionated heparin, it is efficient. The route of administration is IV or subcutaneous, but it may induce osteoporosis or heparin-induced thrombocytopenia, which can be a serious side effect. Laboratory monitoring is mandatory for this treatment, but it is not very expensive. Second, the low molecular weight heparins are also very efficient. They are administered by subcutaneous route, which is easier. There are less osteoporosis, less heparin-induced thrombocytopenia, and there is almost no laboratory monitoring, but they are a little bit more expensive. Then, vitamin K antagonists are efficient. They are oral, which is easier for long-term treatment, but there is an increased risk of bleeding, especially intracranial bleeding, which may be seen in surgical, in neurosurgical departments. And the laboratory monitoring is mandatory with the INR, but it is very cheap. And the last group of anticoagulants are what we call NOAC in English or NACO in French, new oral anticoagulants. New oral anticoagulants like dabigatran, rivaroxaban, edoxaban, and some others are coming. There are some trials which have demonstrated they are efficient, they are oral. There is less bleeding risk, especially less intracranial bleeding. But we have to take care of the renal function because they are eliminated by the kidney and they are expensive. So today we will see what is the place of aspirin in these antithrombotic drugs. Aspirin first became a registered trademark of acetyl salicylic acid, as we say ASA, which had been synthesized by Felix Hoffmann. It was firstly used as an analgesic and anti-inflammatory drug at doses which can be as high as 3 grams per day. In 1971, Vane in England showed that aspirin has an antiplatelet effect on the prostaglandin pathway. It inhibits thromboxane B2 due to the irreversible inhibition of cyclooxygenase. And for this work, Vane received the Nobel Prize in 1982. Here you can see the platelet aggregation pathways, and one of them is the prostaglandin pathway with thromboxane, and it was the place of action of aspirin. In 2007, it was shown by Devi and Carlo Patrono in Italy that platelet activation has a central role in the pathogenesis of arterial thrombosis. And the known effectiveness of ASA was demonstrated in the primary and secondary prevention of arterial thrombosis in the antiplatelet trialist collaboration in 2002. Contribution of platelet activation to venous thrombosis is not certain. It can be related to erythrocyte, leukocyte, and the nets, but it is not very clear. And in the general opinion, platelets are involved in arterial thrombosis only. So we will see if aspirin can be used in the prevention of venous thromboembolism. And the first question is aspirin superior to placebo? And the second question, is aspirin as efficient as the other treatments? Is it non-inferior? So in 1972, it was shown that aspirin, 600 milligrams per day, and for 24 hours before surgery, and 5 days after surgery, was superior to placebo, to nothing. In the 70s, many studies were performed in orthopedic surgery, where the risk of venous thrombosis is very high. And these studies were in favor of aspirin. Then, in 1994, in a meta-analysis with different surgical procedures and high-risk medical patients, there was a reduction of deep vein thrombosis of 20% and pulmonary embolism of 69%. But it was at the price of severe bleeding, significant increase of bleeding, with the need of transfusion, hematoma, surgical bleeding, infections, and transfusion. In 2000, there was the famous PEP trial in hip fracture and arthroplasty. The dose of aspirin was lower. It was 160 milligrams, started pre-surgical, and followed by 35 days of aspirin or placebo. It is interesting to see that in this trial, some patients had unfractionated heparin 2, 18%, or low molecular weight heparin, 26%. In hip fracture, there was a reduction of 43% for pulmonary embolism and 29% for DVT. And altogether, when combining the PEP study and the antiplatelet trialist meta-analysis, there was a reduction of 53% for P, 37% for DVT. And you can see here that the combination of these results show 37% reduction DVT and 53% reduction of PE. Then the question was, is aspirin superior to placebo, not in surgical departments, but to prevent a recurrent episode of VTE? And so in 2012, so rather recently, there were 2 randomized trials against placebo. The first one was called warfarin compared to aspirin. 402 patients. After a first unprovoked episode of DVT treated like usually with vitamin K antagonist for 6 to 18 months, this treatment was followed either by aspirin or by placebo, and patients were followed for 2 years. There was another trial, Aspirin, and as you can see, both of them were published in the New England Journal in 2012. In this second trial, there were more patients. It was the same protocol, and the patients were followed for 4 years. And it was already planned that the result of this second trial will be combined with the result of the first one to have some pooled analysis. Here, you can see that with the warfarin placebo trial, the first one, recurrent VTE occurred in 6.6% per year with aspirin and 11.2% with placebo. So the difference was important, and the hazard ratio was 0.58, so it was significant. In the second study, it was not significant, probably because there were not enough patients. So when the two trials were combined, you see, for venous thromboembolism, but also for major vascular events and clinically relevant bleeding, you can see that there is a decrease of venous thromboembolism, significant decrease, a significant decrease of major vascular events, it's about the same, but no significant increase of bleeding. And finally, very recently in 2014, these results of the two trials, Warfarin and Aspirin, were combined to make a patient-level analysis. The purpose was to more accurately estimate the effect of aspirin treatment overall, but also on individual outcomes and in predefined subgroups of patients. The pre-specified subgroup concerned the type of the VTE event, DVT, PE, or both, sex, age, anticoagulation duration before aspirin, and body mass index. The results show that aspirin reduced recurrent VTE, reduced major vascular events. There was a low major bleeding rate, so it confirmed the previous analysis, but also after adjustment for treatment adherence, it was shown that the recurrent VTE was reduced by 42%. And looking at the pre-specified subgroup, it was shown that there was a larger absolute risk reduction in men and in patients over 65. So we can say that the aspirin is superior to placebo, but is it as efficacious as other treatment? Is it non-inferior? There were first studies comparing unfractionated heparin, low molecular weight heparin, or danaparoid, and results of aspirin were inferior. The doses were very different, I would say, between 200 milligrams and 1.3 grams. There was also a study in long-haul flights, and it was a randomized trial, high-risk patient, and it showed that with aspirin, 400 milligrams per day for 3 days, started 12 hours before the flight, there were DVT in 3.6% and no DVT in enoxaparin patients. In 2013, a randomized multicenter study was performed, and the aim was non-inferiority after hip arthroplasty. It has to be focused that after 10 days of dalteparin, the randomization was done between aspirin 81 milligram and dalteparin 5,000 units for 28 days. And the recurrent episodes were less frequent with dalteparin, but there was non-inferiority of aspirin versus dalteparin and no increased risk of bleeding. If we look at the recommendation of the American Society, American College of Chest Physicians in 2012, you can see that aspirin is on the same level as low molecular weight heparin and new oral anticoagulant for major orthopedic surgery. We recommend the use of one of the following, and aspirin is in this list of antithrombotic. But it is said also that we suggest that the use of low molecular weight heparin is preferred to the other agents. So we can say that aspirin is superior to placebo, but the non-inferiority or same effectiveness has to be considered again in other studies. So in conclusion, first I must remind you that aspirin should not be used for the treatment, for the initial treatment of VTE or the primary prevention of VTE. We were talking about prevention in surgery or prevention in medicine after a classical treatment. So after total hip replacement or total knee replacement, aspirin is efficacious compared to placebo, but less efficacious compared to low molecular weight heparin. It is non-inferior to dalteparin, but after 10 days of prevention with dalteparin alone. If we look after a first episode of unprovoked VTE treated for 6 to 12 months with vitamin K antagonist, it has been shown that prevention of recurrent VTE aspirin is efficacious as compared to placebo. The advantages of aspirin is that it is inexpensive, oral route, no laboratory monitoring, but there is potential bleeding too, especially GI bleeding. So at present, aspirin is usually suggested for patients who have a contraindication to the other anticoagulants or when the other anticoagulants are not available. Thank you.